It works really for all types of rejection. In our case, has worked on both mixed T cell and is extremely good for antibody-mediated rejection. That is something we have been impressed by.
Hi, I'm Haas Tabriziani, the Senior Medical Director of Organ Health and Transplant in Natera. I'm so excited to have Dr. Millie Samaniego, the Medical Director of Henry Ford Transplant Center with us. She's going to share with us her experience and knowledge of using cell-free DNA testing, and also how did she implement this test in her surveillance protocol in monitoring these patients. She has interesting conversation about the patient's perspective and how do they value this test of monitoring their kidney transplant. I'm very happy to be here with you, Dr. Samaniego, and talk about our cell-free DNA testing, Prospera. Thank you very much for your time.
Thank you for the invitation and the opportunity.
I want to jump in and ask, since you are one of the pioneers using the cell-free DNA testing in your practice, how has been your experience using cell-free DNA?
It has been good, especially it has added to my ability to diagnose my patients with more certainty, I would say, and to guide the treatment much better. It's a great monitoring tool.
And how did you start using the test?
Originally, I was interested in the studies that were published, and we decided to start using a protocol since we understood that the test needed to be done serially. So a single test was not a good way to use the test, but it was more a movie as opposed to a single picture, right? So we decided to use the same protocol that was established in the Prospera trial, and we had continued to use it that way. With time, we have learned which are the patients where it works better, and we need to do it more frequently, and on those that we don't have to do it as frequently.
Very nice. So you're telling me about your experience about the proactive study.
Yes.
How has been your experience with that?
Excellent. In the proactive study, first of all, we learned to much better how to interpret this test. And one thing is clear, this test is very good to detect any injury in the transplant. But if we want to use the test exclusively for the diagnosis of rejection, I think the test using the absolute counts and the percent count actually helps you to focus on that diagnosis of rejection and takes the noise of infection, BK, DGF away.
Have you found that this test works better in certain type of rejection or a certain type of patients?
It works really for all types of rejection. In our case, has worked on both mixed T cell and is extremely good for antibody-mediated rejection. That is something we have been impressed by.
Perfect. Glad to hear that. So what do you think is there's the obstacle of the physician who just learned how to use this testing? What is your recommendation for those physicians?
Well, as any other test, it's good to understand the pros and cons of the test, the advantages of using it, how to use it, and to understand the test, what kind of information you can get from the test. Many times we just pick things here and there from what some of our colleagues say, but the best way to do this is to try to look for some of the published data utilizing the different tests and then really get down to it, read it, and if there are questions, just contact the experts.
Very good. Glad to hear that. And since we're very excited to talk about our new interim analysis of proactive data during this ATC conference, did you get a chance to review those interim analyses and what is your thoughts around them?
Well, I think the results are really encouraging. First of all, again, the ability to focus primarily in the outcome of rejection. It is also interesting that this test can predict whatever you want to call the molecular rejection. In many cases, we had found that the levels of the cell-free DNA test go up. We biopsy the patient. We don't follow any histological injury. But as long as the test is high, eventually the patient will have rejection. So we have learned that when we see the test that was, let's say, in the quiescent negative range, goes to this gray zone and eventually to a positive zone, even if the biopsy is negative, if the patient has risk, we follow those patients very closely and prefer to treat.
And can you tell us a little bit more about your protocols? How did you guys come up with the protocol? What did you choose to do?
Well, we prefer to do to take the first couple of samples after the immediate period post-transplant has occurred, right? So during that time, whatever has happened during the procurement of the organ, toxicity, or whatever infection the patient has had, then it has already faded away, so to speak. So we start at 1 month, usually after the transplant, and continue to follow them the first 3 months on a monthly basis. If everything continues to do fine, then we go 6 months, 9 months, and 12 months. And it depends also. If the test had remained negative, there is no need to make any changes. But as soon as the test becomes positive, then the protocol has to change. And what we chose to do when the test became positive was to biopsy the patients to really understand what was happening in the transplant. And along with this, we will order other tests. We will order donor-specific antibodies, because that's our protocol. If you biopsy a patient, you also add DSA and BK PCR, which are the most common tests that we do in patients with dysfunction. And based on what we find, if once the patient is treated, we also follow the levels. And it correlates fairly well with response to treatment.
Very nice.
And in some occasions in which we had seen that after a period of quiescence, it peaks again, we biopsy the patient again, and we find that there is recurrence of
Very
the
interesting.
rejection.
Very interesting. And how has been your experience about adding the two threshold algorithm and adding the score of the quantification of the donor-derived cell-free DNA just to the fraction?
So in the beginning, we used to find that if there was a little bit of DGF, if the organ was, let's say, donor after circulatory death, there was still in the what we used to call the gray zone, right? It was not 0, it was not 0.2, not 0.3. Sometimes it will be 0.4, 0.6, but didn't get to the positive threshold of greater than 1%. Now, if you just look at that, that tells you that there is something going on in the transplant, in the graft. But if you add then the percent, the fraction will not be elevated. The fraction will be within the normal range. Yeah, within the threshold. Which essentially what it tells you, there is an injury event, but it's not rejection. So it depends on what you want to use the test for. And these tests are meant to be surrogate markers for acute rejection.
So did you have cases that the fraction didn't hit the threshold, but the estimated quant donor-derived, the copies per ml, making you to thinking about, does this patient have rejection or not?
Oh yeah, BK is the best example about that. And if you are not going to use the fraction in there, just the absolute number, actually for BK it works really, it's very interesting. The higher the viral load, the higher the absolute count. And then when the infection starts improving, it starts coming down. But again, if what you want is to diagnose as a surrogate marker acute rejection, then you need to use both metrics, both tools.
And you mentioned that there is certain type of patients, for example, if they have positive tests or if they have rejection, you're going to have a different frequency of how to check the Prospera. Is there any other type of patients, for example, the one that you consider high risk, that you're going to monitor them differently?
Or absolutely. What we had found in as the result of the study is that patients who have a high immunological risk to begin with, patients that have a high PRA, some other patients that just by the profile have a higher risk, multiparous females, previous transplants, etc. The test works very well on those patients in telling us that the patient is quiescent versus telling us that there is something brewing there and we need to pay attention. Much better than any other marker, much better than serum creatinine for sure,
For sure,
or
yeah.
even EGFR and proteinuria. Much earlier, you see that the cell-free DNA assay goes up.
Very interesting. So tell us about your opinion about general nephrology who are taking care of these long-term kidney transplants patients using the cell-free DNA testing in their practice.
It's interesting. The general nephrologists many times get this information from their own patients, right?
Interesting.
Yeah. Oh, yeah, doctor so and so is ordering this test. And frequently they call us. What we usually tell them is that in the beginning, until they become familiar with the test and understand how to use it, we can continue to monitor the results of these tests. And we like this because it actually keeps the patient in contact with the transplant center, especially those patients that we send to the community and that live hours away from the transplant center. The patients understand the benefit, especially those in which we had to do an intervention on the basis of the results. And they call us and said, when is that they're coming to get my blood drawn? Or I haven't received my kit. When do I have to go to the lab? So there, I think overall has also educated the patients.
Perfect. So you just saying that the patients understand the importance and the benefit of the test.
They understand it, and we have to explain that to them. Once they understand that the tests have the potential of catching rejection very early on, they are very interested in having this test done.
Yeah, I totally get that because the transplant patient waited so long to get that organ.
Absolutely.
So they really wanted to take care of that organ.
Absolutely. Yeah. Certainly.
And what do you think is the best way to educate the general nephrology physicians about these tests to become familiar with the test?
Well, I think that first you need to, we are always searching for the perfect interaction between the transplant center and the referring physicians. So perhaps the staff from the transplant center, the faculty that is familiar with the patient and has a relation already with the referring physician, is the best person to educate them and bringing them examples of patients from their practice that had benefited from the early diagnosis that you can achieve with the test is the best way to do it. And encourage them to call us and to how to interpret the test if they have any questions.
So some holding hand at the beginning.
Exactly.
And then,
exactly. And for them to also understand that has to be done on a protocolized fashion. And also that they believe. That's what I find more difficult in the beginning, even with my own partners, that they see the result and they believe the significance of the result. It takes time, but they catch up.
Yeah, I think anything new has those challenges, and it looked like you have a great plan the way that you did it in your center by biopsying them, trying to learn about how to use this test, and you get to this point that you can use it in all of your patients in a protocolized manner. Can you tell us a little bit more about the patient perspective of using this test?
I think the patients, when they understand the importance of the test in managing their own medical care and their transplant health, so to speak. So I think patients appreciate that. And they also ask me, oh, I had my test drawn 2 weeks ago. What did it show? So it shows that the patients are involved. We invest a lot of time, our coordinators as well, explaining to the patients why this is important. And one of the things we'll say, well, for how long I'm going to be doing this. And I always think that probably the test becomes more important as the patient is farther out in their transplant history. Because in the beginning, there is such a close monitoring, right? But it is later on when you don't get labs every month. It's maybe 1 month you do, 1 month you don't. To use this tool will tell you when there are problems. Problems usually start after the first year post-transplant.
Yeah.
Not, it may have during the first year, but mainly after the first year post-transplant, this test will be very important.
I know that at the beginning, a lot of the people who use these tests on their patient was under some kind of a study because we all try to learn about how to use these tests. And now there is those transition time that from those people in the study, more people are going to use that in their practice, not as a study protocol, but as the protocol of monitoring their patient. How has been that transition?
Well, first of all, we train the coordinators. That's the first step that we do. And even before we train the coordinators, we get the approval from the different committees in the institution that approve for the test to be done at the laboratories. And we were very surprised. Well, not really surprised. We were very happy to see that they approved the test, and that as opposed to other tests, we're doing it now in 2 different laboratories. And one of those laboratories is in the area where we get more referrals in the urban or in the metropolitan Detroit area.
Obtain the samples.
Yeah, obtain the samples, exactly. Yeah. So the patient doesn't have to be coming to the main hospital downtown. They can get the test done closer to where they live, and they like that very much. And the coordinators are also trained, as I said. They explain the importance of it. We also reiterate that. Many times they come to their visits and they ask for the results, and they ask why, for how long we are going to continue to do this. That's a common question. And we said, well, in your case, in all cases really, we would like to continue to do this periodically as long as we can. The farther we are in the transplant, the better. So we will be able to catch things on time. But at the same time, if the patient has had earlier problems detected by the test, then we said, yeah, you do need this.
More frequently.
You know, you need this more frequently. It's not part of the study. It's the standard of care of the follow-up we're going to have in patients like yourself. The same way that we do monitoring of donor-specific antibody, for example.
Very good. And what do you want to see? Like what data, what information you're looking forward to find out from proactive study and similar studies to help you guiding in how to use this test?
Well, ideally, I think that that's what we all want to know, is the impact that this test will have in the outcome of the patient. Unfortunately, outcomes in kidney transplantation take a long time in become manifested, right? So it's not going to happen in 6 months. But there are some markers that we can have. You know that looking at the performance of the test, let's say 3, 6, 12 months, is probably very likely to tell you how the patient is going to be doing long term.
Later on down the road.
But the main goal of a test like this, I think, is to demonstrate that we can achieve better outcomes.
Okay.
I think we have excellent immunosuppression right now, but we were lagging on having good diagnostic tools. But now we are having good diagnostic tools.
Very good. Glad to hear that. And on the last note, what is your recommendation for the physicians taking care of a transplant patient to use this biomarker?
First of all, become familiar with the test. There are very good studies that have already been published and are very easy to have access to. And do not use a random test here and there. If you're going to use it, try to establish whatever protocol you think is reasonable for your population, but use it in a planned, protocolized fashion, not on an indiscriminate way, because it's not going to help you to reach the results that you want.
Great point. Thank you very much for your time, and I hope you enjoyed the ATC.
Thank you, Gus.
Thank you for joining us. And don't forget to subscribe so you'll be notified regarding the amazing conversations that we're going to have with other primary investigators of proactive study.